detailed bios. So I'm just going to introduce to you Heather Black, Dr. Heather Block from Flinders University, locally here in South Australia. Heather.
Hello, thank you everyone. Can you hear me okay? Great, my name's Heather, I'm an OT, but I'm also a researcher at Flinders Uni. It's a pleasure to share some of my PhD findings with you today, but specifically I'll be talking about the barriers and enablers and implementation strategies for managing challenging behaviours after TBI in the acute hospital setting. Is this a clicker? Green. Okay, there we go, excellent. So behaviours of concern or challenging behaviours are an umbrella term that encompass a range of behaviour changes that are listed on the slide here, but they are really common after a traumatic brain injury, particularly in that acute phase of recovery and when someone's going through post-traumatic amnesia. And these challenging behaviours can present many risks of harm to patients, to staff, and also are very distressing to family members. Now, ideally, TBI behaviour management should be a comprehensive, multidisciplinary, consistent approach, starting with non-pharmacological interventions before progressing to pharmacological interventions or the medications. And ideally, we should minimise use of restraints with patients. But there is variability in the care and there's limited evidence around the effectiveness of TBI behaviour management interventions, specifically in that acute phase of recovery. I completed a couple of reviews of evidence and guidelines, and the evidence relating to management strategies is limited and of low quality. And there are some high quality clinical practice guidelines. It's wonderful to hear in the earlier sessions today that there's more in development. But very few guidelines actually detail practical implementation strategies that help clinicians embed and implement recommendations into practice. And of course, that impacts on clinicians' knowledge, confidence, and skills. So there was a need to understand the context of the acute hospital setting and how these contextual factors can influence implementation of improvements or innovations in clinical practice for patients with challenging behaviours after TBI. So that took me to my PhD research aims, which is around developing and implementing a consistent behaviour management approach for patients with TBI in 2 hospital settings, and then to explore the barriers, enablers, and develop some implementation strategies for improvements in this area of practice, but specifically for the acute hospital context. So I'm going to whiz through a few studies and give you an overview of the findings, but if you do want some more information, you're welcome to email me, or I do have the publications up on the slide if needed. So we had an intervention group of 23 patients with TBI who had challenging behaviours in their acute hospital admission, and they received care after implementing a behaviour management approach which essentially outlined a process for assessment, non-pharmacological interventions, and then recommended pharmacological or medications. And then we evaluated their care and compared it to a historical control group. And our findings showed that there was a high level of uptake of the behaviour management approach. We saw patients who received care after the implemented behaviour management approach had significantly lowered use of mechanical restraints and significantly lowered acute hospital admission costs. So we were pleased to see that there was improved quality of care to patients with TBI, but it wasn't a randomised controlled trial. There were some methodological limitations, which meant we couldn't necessarily identify that the outcomes were a direct result of the intervention. And so we needed some further understanding of those contextual factors that can influence implementing new change or interventions within the acute hospital setting, particularly around TBI behaviour management. So I completed a qualitative study involving 4 focus groups with 28 staff from acute and subacute settings who had experience in working with patients with traumatic brain injury. And data were analysed using a reflective thematic analysis and mapped to the construct of the IPARIS implementation framework. We found 4 barriers and 3 enablers. The barriers being that clinicians often find it difficult to make those clinical decisions when there is unpredictable escalating behaviours. Staff voiced concerns about the risks to patients, but also to staff. The hospital environment is noisy, it's overstimulating, it's loud, it's not conducive to a calm, settled environment. But when the staff talked about what was needed for good quality, effective TBI behaviour management, it's going to require intensive resources, particularly staffing, that the acute hospitals, particularly here in Adelaide, don't have. Some of the enablers were around the experienced staff who had the practical skills, and they were really key champions in supporting new and rotating staff. Incorporating person-centred care and teams that felt supported and valued by their leaders enabled their resilience. So, I also gained the perspectives of family members. I completed a qualitative study interviewing 10 family members of patients who had TBI and also exhibited some challenging behaviours in the acute hospital setting. And after analysis, some of the themes that were identified was that, again, the hospital environment can trigger escalating and challenging behaviours. Hospitals often have inconsistent or inexperienced staffing, often the nature of agency or transient staffing, I should say. However, when it was possible, the families felt when there was that right fit of personality between the staff member and the patient, that was really important, particularly when they spent the time to build rapport with patients. And families also voiced an important strategy was opportunities for communication for the patient, which would minimise their frustration. Families voiced that they needed more support and information in this early stage of TBI recovery within that hospital setting, more information about TBI, but particularly around behaviour change. I completed a quick audit and survey of acute staff. So the audit was conducted on 26 medical records of patients during their acute admission with TBI and had challenging behaviours. And we developed the audit template based on our review of clinical practice guideline recommendations. So you can see that, and this was audited after the implementation of the behaviour management approach in the previous study. So we could see there was some assessment being carried out and non-pharmacological and pharmacological interventions provided. We can see that there wasn't a lot of neuropsychiatry input, but we don't have a dedicated neuropsychiatrist within acute hospitals in Adelaide. And patients were often supervised during their admissions, seeing some code blacks and still some restraint use. Education was documented in the medical record, but it wasn't detailed of what that education was and what it was provided to families, and yet families had reported they need more, so I think there needs to be a bit more investigation there. And interestingly, we saw out of the 26 medical records, 54% had a documented incident of an injury, often from the cause of falls, punching, slapping or kicking, and that occurred to either the patient, family or staff. And we see that the patients often are staying in the hospital for about 3 weeks and discharged to brain injury rehab. Surveying, I think it was about 26 acute hospital staff working with patients with TBI, we're seeing that there was some uncertainty in their levels of knowledge and confidence in assessment and management of behaviours. Okay. So then I pulled it all together, wrote a bit of a thesis and made some recommendations. But essentially, we need some more research. I think that's been highlighted in some of the previous sessions. We need more research in TBI, but particularly in effective interventions to support people with behaviour changes. But here we have some strategies that can be quite practical and tangible to implement within hospital settings. Ideally, we want hospitals designed that can be adapted for low stimulation, secured wards, a door so that patients don't run out onto the street or abscond, which was happening, staff training and education through professional development, work instructions, protocols and documentation and handover processes to keep the work consistent. And of course, communication strategies for patients who are exhibiting challenging behaviours. Ideally, we'd like to see increased staffing ratios and better access to specialised staffing in the acute setting, but of course that's funding dependent. And we need to see more family involvement in the care to the patient, education provided to families in that early stage of TBI recovery, and clinicians to work together in a team, but also to feel supported within their team. Now, these implementation strategies are derived from the ERIC compilation of implementation strategies to address the identified barriers from this research, but also to leverage on some of the enablers, but specifically within the context of the acute hospital setting. So first and foremost, improved care and changes requires more funding, which is often hard to gain, but ideally could be policy driven to invest in better care to hospitalised patients with challenging behaviours, and that might come from a clinical care standard at a policy level or more clinical practice guidelines. And then we can use audit and feedback and readjustment to monitor clinical performance and provide feedback and measure how well we're doing. It's the experienced staff with the practical skills who are really champions in the hospital setting to help develop the skills of others and the new rotating staff members. So they're the ones we can build a coalition of clinicians and be the leaders for change. Documentation processes might involve consistent detail and processes and handover that can then be monitored and audited. Regular education and training, but it needs to be dynamic and it needs to be regular because the hospital workforce is so transient and rotational. And ideally, things like a quality toolkit might be helpful in addition to some clinical practice guidelines to really support use of assessment templates, management strategies, and then quality improvement templates and measuring clinical performance and quality improvement. Facilitation is that link between research and practice, and because this area of practice in the acute hospital setting is complex and multifaceted and lots of barriers and challenges, a facilitated approach to implementing improvements that's regular, ongoing, with lots of reminders and feedback processes will be helpful in addressing some of the barriers. And importantly, involving patients and families in the care that they're receiving, but also encouraging them to provide feedback and patient-reported outcomes. Okay, so as I said, we need more research. We need to investigate the effectiveness of non-pharmacological strategies, but also pharmacological strategies, particularly in that acute phase and when people are in PTA. Ideally, we want to see some of the guidelines that are being developed or updated include some practical strategies for implementing their recommendations into practice. We need to evaluate the type of education and training that's suitable for the acute setting to really promote skill development for clinicians. And there really is a need to co-design, develop and evaluate more information and suitable education for families in that acute stage, and particularly around TBI behaviour changes. We see that there are some workforce factors that can be barriers within the acute setting, so around investing resources into good quality effective care and the outcomes around staff turnover, retention and injuries could be an interesting sort of economic evaluation, but ideally we want to see more research incorporating those effectiveness implementation hybrid methodologies because of the multiple contextual factors in the hospital. So ideally we need that future research and policymakers to really drive the change so that we can have funding models that supports effective and high quality behaviour management for patients with TBI in the hospital setting. And ideally we'd like to see a dedicated clinical care standard for challenging behaviours in the hospital setting, because this isn't unique just for people with TBI. We see challenging behaviours arise, and a lot of these barriers arise with other population groups in the hospital. But ideally, the further research, policy changes, and some subtle pragmatic, changes in clinical practice, what we want to see is that better care to patients recovering from TBI, better experiences for their family members, and for hospital staff to feel safe and supported at work. Some references there, and I just wanted to finish up by thanking the Lifetime Support Authority for funding this program of research. And if you do have some questions, welcome to email me. Thank you.
Thanks so much to Dr. Heather Block. I'll get it eventually. My bad. I had it right when I'd hit the stairs. Okay, so that's some lovely things to hope for. And the next group that we're hearing from is speaking about a multidisciplinary team approach to behaviours of concern, one form to rule them all. And we're going to hear from Susan Lane, Tracey Carruthers, and Jessica Skene, all from the Nepean Blue Mountains Local Health District, New South Wales.
That's not us. Is that you guys? Did you want to come up? Looks good, but
that's more us.
That's us. All right. So this project was generated from an identified increase in admissions to the neurology ward of patients with behaviours of concern and an increase in incidents where staff were injured. There was also an increase in the burden of workload on allied health and the CNC in planning for discharge for these patients, and there was no clear direction for the holistic management of patients with behaviours of concern, and it led to increased length of stay and readmissions to the hospital. Oh yeah, that beautiful thing. Yep.
So you can see a few statistics about our local health district there. But Nepean Hospital is a 520-bed teaching hospital, and we provide tertiary referral services to the Nepean Blue Mountains Local Health District. We're also home to 11,428 NDIS participants, which is amongst the highest across New South Wales. So our roles, so my name's Jessica. I'm one of the senior neuro OTs at Nepean.
I'm Tracey. I'm one of the senior social workers.
And I'm Susan. I'm the clinical nurse consultant for neurology. So some of the issues that we had on the road to implementing this tool is that, or some of the issues that we faced have been occupational therapy of leading discharge planning around patients with behaviours of concern, length of time in reviewing medical records to do that report writing, and that each of us individually needed to do that. Coordinating family, nursing staff and medical team regarding identifying triggers and implementing positive supports, education of medical nursing, security specials and the use and implementation of restrictive practices were some of the issues, and handing over that information on discharge to services in the community.
So the role of the OT in this is to determine care needs for patients and to advocate for correct funding, supports and equipment on discharge to ensure a sustainable and best care.
So as a social worker, we often take a case management role with the patients with these complex admissions, additional to the counselling, advocacy and support that we provide.
In the nursing role is for complex discharge care planning, requires a collaboration with mainstream medical and allied health services with both inpatient and within both inpatient and outpatient settings. There we have a brief case study. So AG was a 58-year female who presented multiple presentations to the emergency department on the background of a hypoxic brain injury from 2008. Her informal supports were no longer in place in the community. There was no mental health issues identified. She presented to the hospital requiring management of those behaviours of concern, which included accessing the NCAT services for restrictive practices, and she was at risk of homelessness because she was in a housing property, and because of the behaviours related to her behaviours of concern related to her hypoxic brain injury. And part of the process for AG was an NCAT hearing, and it was probably, which is the National and Administrative Civil Tribunal, which is used in New South Wales. We went to the NCAT hearing without evidence, and it wasn't as streamlined. It was one of the most gruelling hearings that we had participated in. Ended up going well over time. We were there for about an hour and a half, and ended up having to provide supplemental evidence despite what we had prepared in advance for the hearing. So at that stage, Tracey and I were ready for a change.
So we started looking at a project that looked at what all of these organisations require and the specific information, and we actually found some common ground that you can see there. And when we gathered this information and we developed it into the individual threat assessment, which is the template we'll be talking about, we managed to be able to use that for all of our applications for restricted practices. We use it for our NDIS, change of situations, our carer training, compatibility matching, behaviour practitioner handover, determining the need for a dementia-specific unit or a memory support unit. It allows easier acceptance of restricted practices, also allows that for the commission. So for the NDIS Quality and Safeguards Commissions, our behaviour practitioners are often using that as evidence of some least restrictive things that have been trialled and the reasons that we actually require these chemical restraints or whatever restraints we're actually using. So this is an overall summary of the form, and we'll be going through each of the individual sections. So the individual threat assessment was developed in February 2023. It allows for a summary of known history. It's a collaborative document, so it does require the whole team to be involved in it. It provides a risk matrix. It allows for individual person-centred approach to behaviour management. It contains all the information related to the behaviours and interventions within one document, which, as I said before, can be provided to numerous organisations. And it supports the request for security or nursing specials, and also in relation to our IMS management, which is our incident management system.
This form in its current format is not used anywhere else within our state. It addresses the risks, but not just to the physical safety of the patient, but to those working and visiting the hospital environment and or the final destination on discharge for this person. It addresses both the environmental and psychological and property risk as well, because it's not just about the risk to the individual, but property damage needs to be considered, especially when you're approaching organisations like the NDIS. Our ward experiences a high rate of patients with behaviours of concern who have different triggers, and how we allocate those across our limited bed space needs to take into consideration these behaviours. Also, our staffing allocation needs to take into consideration these behaviours as well, and this allows our nursing unit manager to have a complete overview for each patient with behaviours of concerns and the incidents, so that we can start to see a pattern of those behaviours and what is and isn't working. It supports NDIS in developing and completing their own risk assessments during that onboarding process of new participants. And we have used it effectively in informing NCAT panels around the risks of not implementing the restrictive practices, whether they're chemical, environmental, that we are requesting to support discharge for these patients. Control interventions and strategies is a prompt section and also a section you can record the interventions that have been tried or are currently in place. And the action plan allows for something that I think is really important, and that's delegating that task and responsibility for that task to a person or a role, and documenting when it's come into effect.
So now that we're using the form, all of this information is in one spot and it's well detailed. The assessment is started by the ward, which saves the OT the need for that sort of case management role, and is started on admission, so the relevant data is ready by the time the reports are called. This is then provided to the OT, and reports can be completed with one form, saving time reading through every note in the file, completing further observational assessments, and advocating for completion of additional documentation and forms. And how has that impacted us? Well, according to Future Health Report, people over the age of 65 with typically high needs for health system support will be a larger proportion of the population in 2031. So 16% of the New South Wales population is aged 65 plus, and this represents 35% of the activity in the health system. By 2031, 700,000 more people will be over the age of 65 in New South Wales, or 22% of the population. With the anticipated trajectory for the changing age mix of the New South Wales population, if the health system continues with today's model of care, people over 65 will account for 45% of healthcare activity in 2031. There's been an increase in the need to document and apply for restrictive practices within NCAT for this ageing population. Many residential aged care facilities within our area regard a locked memory support unit as a restrictive practice. For a patient prone to wandering, they will require a guardian with the function of restrictive practices to be appointed prior to entering into the residential aged care facility. This leaves the burden of applying for guardianship on the inpatient setting. For the younger population with cognitive impairment, the same guardianship function is required within NDIS supported accommodation for restrictions such as locking the door to maintain the patient's safety. A multidisciplinary approach to document and gather this evidence has saved, on average, 8 hours of clinician time with a patient. This 8-hour saving per patient can be utilised to provide healthcare services to other patients, ensuring a quality and timely services throughout the ward.
So one example that I guess highlights the changes is that we had a 59-year-old male with Parkinson's and Parkinson's-related dementia who presented to our unit in 2021. His behaviours of concern were quite extensive. We got NCAT functions for him for restrictive practices, which included chemical restraint, and managed to manage his behaviours quite well on the ward for discharge. However, once he was actually discharged, the NDIS Quality and Safeguards Commission found that there was insufficient evidence to say that we tried the least restrictive because the behaviour practitioner did not have any evidence of what was done in hospital. They then ceased the chemical restraints in the community and he bounced straight back into our ward again.
And the following case study is Mr. J.H., who was our most recent discharge. 61-year-old male presented with behaviours of concern, newly diagnosed in the community. His behaviours of concern were still significant but less in the scheme compared to ES. So just wandering and absconding, no damage to property or threats to others. And at the NCAT hearing, supported by our individual threat assessment, which showed how we had tried to use the least restrictive means, we were granted restrictive practice for chemicals, which were not currently in place to future-proof for this gentleman, environmental restraints, a 2-year order, and no issues with the NDIS Safeguards Commission.
So in summary, patients with behaviours of concern are a vulnerable cohort within our hospital system. Working collaboratively to identify and address these behaviours of concern in an ethical and patient-focused manner ensures that the safety and wellbeing of the patient is a priority. The constant monitoring and reflection of behaviours also ensures that the right treatments are being used and that restrictive practices are only used where essential. It allows for effective communication between health and all the other organisations, such as NDIS and NCAT, ensuring the safe and legal use of restrictive practices for patients on discharge. This assessment has a focus on ensuring the safety and wellbeing of both the patient and staff within the ward. The form is a tool that allows clinicians to work collaboratively together to improve the health outcomes of our patients and the safety of our staff. Identifying these behaviours of concern, triggers, patterns and suitable de-escalation strategies allows for an individualised and tailored intervention to be put in place to ensure the safety of staff and patients. Thank you.
Don't forget your phone. Don't forget your phone.
Please thank again Susan Lane, Tracey Carruthers and Jessica Skene for that very rapid-fire tour of a Bonza form. Now, our last presentation for this session is the Behaviour Resource Group, which is an interdisciplinary model for positive behaviour support in an inpatient brain injury rehabilitation unit. So we're going to hear from Lauren Bannard, Joshua Butler, and Sophie Flint. Welcome.
Okay, let's make a start. We're going to present on our Behaviour Resource Group, which is a key component of our inpatient service. So we'll all be presenting on that today. A little bit of background. The Brain Injury Rehab Unit, or BIRU, is a 24-bed inpatient unit with an interdisciplinary model. We have adults aged 17 and older who have moderate to severe ABIs and TBIs, and they come from South Australia, Northern Territory, Western New South Wales and Victoria. We receive referrals from all those areas, primarily from the acute sector, as well as from the community stream as well. Length of stay can really vary. So typically, we're likely to have people as part of our service from anywhere between 2 weeks up until 2 years. And patients are often admitted while in post-traumatic amnesia. For ease, today we'll refer to the people that we work with as patients throughout the presentation. So there's a lot of different challenging behaviours that we observe on our unit. We have a list of those that are most common, including agitation, physical aggression against others, self or property, verbal aggression, perseveration, absconding, wandering and intrusiveness, impulsivity and disinhibition. It is also common for our patients to have concomitant mental illness, substance dependency and socio-economic challenges, which often have a further impact on their behaviours of concern. All right, so the group has evolved over many years to what it is today, and it's fair to say that the three of us have been involved for most of this journey. It commenced in 2012, where the Behaviour Resource Group, or the BRG, was formed, initially by our clinical psychologist as well as one of our OTs, in response to observations about the inconsistent approach to behaviour support on the unit. The group first met in 2013 with the aim to train behaviour champions to promote the positive behaviour support model. Through 2015 and 2016, the BRG created online learning modules, which are now a standard part of staff orientation. From 2012 to 2017, our clinical psychologist took the lead with behaviour assessment and intervention. During periods of leave of our psychologist, other members of the BRG stepped in to support the team alongside the neuropsychologist and the neuropsychiatrist. In 2022, staffing changes included vacancies with psychology and psychiatry roles and reduced neuropsychology. So we had two options, adapt or die, and we chose to adapt to the model that we run with today. So the core members of our BRG consist of physio, OT, speech and social work. Our nurse unit manager and a senior nurse also attend our consult sessions. We also have involvement from medical staff that become involved as required. And we found it valuable to have representation from various disciplines as we each bring our unique set of skills and perspectives. And we firmly believe that behaviour support is everyone's role, as a consistent approach is key. Today, the BRG offers 2 streams of support, our consultation sessions, as well as education and training resources.
So today we will talk about the BRG consultation sessions. The session is a 60-minute scheduled session led by the BRG. We are currently offering 1 allocated time for a session each week. It is the role of the treating team members to refer a patient with a behaviour of concern to the BRG and for all team members to attend the consultation session. Sessions are either an initial consultation or a follow-up review session. During the session, the BRG guides the team through a functional behaviour assessment, and then the BRG supports the treating team to develop strategies to trial. Review sessions can be scheduled as needed, and they are usually 2 weeks after the initial session. The purpose of the initial consultation meeting is to develop a clear description of the behaviours of concern in observable terms and identify the priority behaviour to target. Review the completed behaviour logs from the team. Develop a list of setting events and antecedents identified by the team. Develop hypotheses of the function of the behaviour. And finally, develop a clear plan for the team to test and implement. The purpose of the follow-up meeting is to review the previous actions from the previous session, review the outcomes from the behaviour plan that the team has implemented and tested, and this could include what has and hasn't worked well to reduce the frequency or intensity of the behaviour, and review any changes to the patient's behaviour and complete a new functional behaviour assessment as indicated. So here is an image of our current referral form to the BRG. So you can see this includes the patient details, the presenting behaviours that have been identified by the team members, and the impacts of the behaviour and the priority. And this is a copy of our current behaviour logs, which can be completed by any team member to support gathering data. This gathers information around the time of the day of the behaviour episode, any identified setting events and antecedents or triggers, a description of the behaviour of concern in observable terms, and any actions taken by the individual and the response from these actions.
So our BRG behaviour plans cover a range of different things. It's not just thinking about the behaviour itself, we're trying to look at the whole person. Almost all of the people that have behaviours of challenge on our unit also have cognitive and communication changes, so we look at that as well as part of our behaviour plans. Josh, Donna and myself have been lucky enough to been recently trained in the PBS Plus approach through a partnership with Monash Uni, so that does influence a lot of the language we use and a lot of the approaches we use. A really big part of what we do with our plans is try to focus on the person rather than just thinking about the behaviour or labelling that person as being behavioural. So we take a lot of time to get to know, who that person is, what are their values, what was their previous roles, their previous routines, interests, culture, spirituality, all those things that make a person a whole. Our behaviour plans focus primarily on proactive strategies, and we try to think about all aspects of a person's day. If you came to the workshop on PBS Plus on Tuesday, some of this terminology might be familiar to you. These are some of the key areas we try to focus on in our plans. So we look at feeling well, which is things like, optimising pain management, considering mood, continence routines, sleep-wake cycles. We look at the environment, so where the room is located on the ward, how the room is set up, what kind of orientation aids have they got, is there too much visual clutter, physical clutter. We consider interactions as well, so thinking about scripting, communication style, preferred people that they might see in their day, thinking about relationships. Routines are a really, really key part of what we look at. So we look at how we do our timetabling, considering fatigue management within that, making sure that we're giving people adequate space for rest. We even think about how ADLs are structured, how exercise is incorporated into routine, meals, prayer, phone calls, all those things that we gathered information about that person, and we try to incorporate that into their usual routine, or their new routine, on the ward, with an overall goal of trying to increase independence. Meaningful activity is also really key. So we incorporate projects. We try to work on meaningful goals for the person. Look at things like, community outings, weekend leave, social opportunities on the unit, jobs, all those things that give a person a sense of meaning and try to tap into that identity. And then, of course, skill building. So alongside all of this, we're looking at what are some of the skills they need to build to support them to reduce those behaviours. So whether that's around their communication, self-regulation, might even be cognitive strategies we're looking at. So there's a lot. In terms of outcomes, we haven't done any kind of amazing research. We'd love to, but we're clinicians and we don't have time. But we have found, just from kind of looking back over the people that we've reviewed through our BRG, in the current format, all of the patients we've reviewed have had a reduction in the frequency and/or intensity of their behaviours. We've even had some people who initially were flagged to discharge to supported accommodation end up at home, which is an amazing outcome. We're just, subjectively finding that staff are now using a common language when we're talking about behaviour. So as a team, I think, we're kind of singing from the same hymn book. We've recently done a survey, and we've found that staff have said they value this resource, so that's always good. And overall, staff confidence seems to be improving. We haven't measured this, but this is just something we've observed. We've been doing these BRG sessions for many, many years now. And I think we've noticed that staff are now coming along to these sessions saying, I've tried this, I've tried that, I had a go at this. And to us, that's a sign that this has got to be doing something useful. And I think overall staff seem to be less risk averse with us, role modelling this trial and learn approach, this experimentation approach. We're trying, there are some patients who have quite high risk behaviours where it would be very easy to not try things, like someone who's an absconding risk, not trying mobilising on the grounds, or someone who's aggressive, not letting them cook the barbecue. But we're trying to take those risks and allow people to have those opportunities, and it's actually paying off. So, in terms of what's next, we've got so many good ideas. Time is the challenge, as it is for all of us. But through our advocacy as a group, our organisation has actually agreed to fund a positive behaviour support practitioner role for our inpatient unit. So that's being recruited to currently. We're very excited to see what opportunities that might give us to really look at how we do behaviour support on our unit. We'd love to, we've actually now got a clinical psychologist, which is amazing, so we want to look at how we can incorporate psychology back into the BRG. We'd love to look at outcome measurement, try to be a bit more consistent, so exploring something like the overt behaviour scale and how we might be able to use that on our unit. We've been writing a terms of reference to make us a little bit more legit, so we're going to finish that. And then we want to do a big body of work around education for staff on our unit and look at family education as well. So that's us. Thanks.